Thereafter, his protein levels had reduced in proteinuria when the mother had done proteinuria testing at home, and it had been between +1 to +2 whenever she tested it. And she goes to clinic follow-up twice a month. And the third relapse was yesterday when she had come for the clinic follow-up, and the child was investigated and was found to have a urinary protein of 4+, after which the child was admitted. Further investigations done also showed that the child's cholesterol levels were elevated this time, but the blood pressure was normal. The mother did not complain of any joint pain or rash in the child, no any abdominal pain or icterus. The child also does not have any visual abnormalities or and investigation did not find elevated blood sugar levels due to steroid use. But the mother did mention that his height is low for his age. No any other special investigations had been done, and the mother is well aware of how protein testing is done at home and about its results, how to read the results of it. Regarding his past medical history and surgical history, they are insignificant. He does not have any allergies to food, drugs, or plaster. And regarding his drug history, he has not taken any other medications except prednisolone. Regarding his birth history, he was born at POF 37 weeks by a low segment cesarean section. And on inquiry, I couldn't completely understand why a cesarean section was done, but his birth weight was 2.7 kilograms. In the antenatal period, the mother had taken all her supplements properly, as she did not have any fever with rashes. And throughout pregnancy, she has been taking her supplements properly and had gone to the MOH in her area, the Hanwell area, and all investigations done during that time were normal. During the postnatal period, the child had a good cry and was breastfed, and there were no NICU or PBU admission or any. The mother did not notice any yellow discoloration for the child. Immunization history of this child is up to date, with the last vaccine being given at 18 months of age, which is the DTP and or fourth dose and oral polio vaccine, and no any other additional vaccines were given to this child. The development history was age appropriate. The mother says that the child runs around and plays, and he can hold a pen and he scribbles stuff on paper. Regarding his gross motor and fine motor, his speech and hearing and social were also good. There were no any problems found. Regarding family history, there is no family history of nephrotic syndrome or any renal conditions in the family. Regarding the social history, the child lives in his own home with his parents and an older sister who is 9 years old. The husband, the father of the child, works as a driver and earns 50,000 per month. The mother did not complain of any financial problems, but regarding regarding extended family support, it was poor, as most of her siblings and mother lived far away from home. The closest hospital to them is in Avusawala, and she said they have their own vehicle to travel. Regarding the examination now, on examination of the child, his weight was 14.7 kilograms, which was between median to +1 is standard deviation, and his height was 90 centimeters, which is between 1 standard deviation to 2 standard deviation, minus 2 standard deviation. On general examination, the child was well active and playing on the bed. He did not have any dysmorphic features, uh, and he was afebrile, and but he had a bit of facial puffiness, and there was no ankle edema. On examination, the abdomen proper, on inspection, there was no visible abdominal distension. There were no scars or any visible veins. Uh, on palpation, there was no tenderness or palpable masses, uh, and no any organomegaly. On percussion, there were no regions of uh, uh, dullness suggestive of fluid accumulation. And auscultation, bowel sounds were normal. Regarding his CVS examination, his heart sounds were normal and blood pressure was 100/80. His, I have forgotten to write his pulse rate. Yeah, that that's about it, CD, regarding history.
Okay, that's good. May yeah, have few things to add. So first one was I'll just tell the things that I saw, and ඊට පස්සේ I will tell like from the beginning how to present කියන එක again I will tell. Your history
Okay.
is good, right? The first thing is like you said, this is the third relapse of nephrotic syndrome. That is fine. You can tell that. But the problem is like it's better if you can describe the current episode, telling like the possible like the differentials for this episode to tell like this is not transient proteinuria, like you can tell some words like there is no intercurrent illness and the child was fine, right? And no medication usage, like that you can tell. And also like they also get proteinuria with an allergic reaction, right? So that sort of two or three things you can tell that this about this particular relapse before going
Mhm.
back to the original like initial very first episode and talking about that, right? So
Yes.
for the very first episode, you spoke about the differentials. That was very good. But like try a little bit to give differentials for this particular relapse also to tell that this is a relapse, right?
Yeah.
Right. Otherwise, like that is also fine. But I just told that. Right.
Yeah.
And the other things I found was like you said the patient is only on prednisolone. Like for
Yeah.
the drug history, that's okay if the mother says like that, but usually they are on vitamin D and calcium and all, everything. No, so better don't say things like that. Only on prednisone, එහෙම කියන්න. Right? And
Okay.
other thing was your birth history, like that's fine. Like even if you can't understand, just say that because like nephrotic syndrome is not much related to the may birth history now. So you can
Yeah.
say antenatal, may postnatal, all these periods are very like those are uncomplicated and is delivered by the C-section killer, right? And
So we don't need to describe the whole thing.
no, it's not related now. If it is like a CP history, then you have to may describe it in a like a better way, right? Okay.
Yeah.
And the
Okay.
other thing is development history. Like it will be better if you can tell like gross motor, fine motor, like break it down into the domains and then present it. Then it will be
Okay.
okay.
Mm.
And the like in the social history regarding the finances, you said like it's around 50,000, and the mother didn't complain about any issue. Yeah, that's
Yeah.
fine. The mother won't complain. Like even nowadays, like anyone can understand they can't live with 50,000. So you can
Yeah.
tell like they are only receiving 50,000, and they have multiple financial issues because of this scale. Like even if they're receiving like 1 lakh, you can still say like
Okay.
because you can make it a problem, right? Okay,
Okay.
so always make that a problem because like you can mention about some allowance like Aspesumo or something in the management plan, and like that will be an additional point, no? Right?
Okay.
Then in the examination, what I noticed, like you mentioned about the edema in three parts. That was really nice, right? You talked about the facial edema, ankle edema, and periorbital. Like that was really nice. And then the blood pressure, when you're telling the blood pressure should be mentioned in centiles, right?
Oh. Oh, okay.
So you didn't tell the centiles.
Yeah.
And the other thing is you didn't tell about the respiratory system. So I was expecting to you to tell like whether there is a pleural effusion or something in the respiratory system. And
Mhm.
neurologically also you should talk about the like at least you can ask the child to jump up and down. And then like if the child is able, you can say upper limb, lower limb neurological examination is okay, and you can like flash a torch or something and check the cranial nerves and just say that the cranial nerve examination is also okay, right? Atica,
Yeah.
you can, those are the main things that I found. So do you have problem list?
Yes, I do have problem list. I have summary as well. Shall I present both of them?
Yeah, yeah, yeah. Sure.
Okay. Uh, uh, my summary is that Vihas is a 2 year, 10-month-old child presenting with the third relapse of nephrotic syndrome within a 6 month period, associated with elevated cholesterol levels and growth faltering. His past medical, surgical, and allergic history are unremarkable, and for drug history, he's on prednisolone. Uh, his development is age appropriate, and immunization history is up to date. Social issues of poor family support were identified. My problem on examination, he had facial puffiness and height of which was between -1 SD to -2 SD, and a weight which was between +1 S median to +1 SD, and uh, and uh, and blood pressure was 100/80. Regarding the problem list, this child has steroid dependent nephrotic syndrome, growth faltering, and poor family support.
Okay. Um, the summary, okay, like you need to improve a little bit on the summary. Are cholesterol, high cholesterol, I don't think that is needed to be in the summary. And you don't need to mention the parameters per se for the summary. You can just like එකත් කිව්වත් කමක් නැහැ. And අර blood pressure values කියනද you can just say because this is nephrotic syndrome now. Anyway, they
Yeah.
won't be hypertensive unless there's a reactive hypertension. Hinda, like you can tell the child is hemodynamically stable, not in hypovolemic shock. That is more than enough for us. Ne? ඒ ටික
Okay.
කියන්න summary, I don't think like if your history is very long, you won't have time to present the summary no. Like
Yeah.
exam like I don't think summary nang may. And the problem is steroid dependent nephrotic syndrome was one. Other things,
Growth faltering and poor family support.
growth faltering. Okay. Uh, okay. So growth faltering means short stature, neither.
Yeah.
Okay. So when you're presenting like something like a short stature, you should be prepared like they can take it to any length, right? Short stature kiwagama. So
Mm-hmm.
that you can you remember that entire graph is there in the මොකක්ද අපේ පොතේ? There's an entire graph how to
Yeah.
analyze the short stature. They can ask anything from that graph, right?
Mm-hmm.
So okay, other thing is other problem.
The problem is poor family support, extended family support.
Okay, that is also good. And if you had added the social problems, then that will also be another problem, right?
Mm-hmm.
Because like obviously you know the name Aswesumana, so you can easily tell that allowance and those allowances you can arrange kila එහෙම කියන්න පුළුවන් නේ, right?
Okay.
Other thing is like now this child you said the no additional vaccine was given kila නේද?
Yeah.
So that also can be brought up as a problem. They should be receiving pneumococcal vaccine.
Okay. Okay. Okay.
හරිද? So you
Yes.
can mention that, right?
Okay.
Right. ඊට පස්සේ okay. Now I will tell you now from the beginning මම කියන්නම් මේ කොහොමද how to present the history කියන එක. ඒකේ අර
Mm.
introduction was okay, right? You said මේ this year old child එහෙම එහෙම කියලා කිව්වා, that is fine. ඒකේට
Mm-hmm.
like when you're telling the mother's education level for this sort of a chronic condition, more than mother's just education level, you need to know the mother's level of education about the disease. හරි. එතකොට that's fine to tell the education level, but if you can present something like a mother who is very well educated about the current condition and the medications, so some word like that, that will be very good, right? So ඒක එහෙම එකක් කියන්න.
Mm-hmm.
ඊට පස්සේ then the presenting complaint is fine. right? And then the main thing is like once the moment you say the presenting complaint, this child came with the third relapse. That is not the presenting complaint, right? So
Okay.
presenting complaint should be something like the child was admitted from the clinic with a 4+ proteinuria for I don't know, like for this many days, right?
Okay.
4+
Okay.
proteinuria, and you said there's some facial puffiness was there in the examination. The
Yeah.
mother wouldn't have complained that to you. But like the moment you get a proteinuria with some edema, then obviously that's an indication that the child is in a relapse and they should be admitted. So if I were you, I would have changed the presenting complaint into the edema part. I would have brought up the edema, right? So
Uh-huh.
recent onset මොකක් හරි periorbital or facial edema for 2 days along with the 2+ or 3+ proteinuria, right? So
Okay.
then that is very clear for the examiner that you are talking about the relapse. Okay, but
Okay.
still I would go back and I will describe that this child is in a relapse scalar. I would exclude all the possible differentials, including transient proteinuria. Like I will say the child was fine, no fever or any other recent onset infection, intercurrent illness, and no
Mm.
dysuria, hematuria ටික කියලා. ඊට පස්සේ allergic reaction එකක් වලට they get proteinuria. You can talk about a skin like this skin bite or something like bee or someone, and then
Mm.
heart failure features පොඩ්ඩක් චුට්ටක් කියන්න. No previous history of a cardiac condition. අර
Mm.
scalp sweating, no difficulty in feeding, ඊට පස්සේ tachypnea මොනවා හරි තිබ්බද?
Mm-hmm.
Not known to be having chronic kidney disease හරි මොකක් හරි කියලා CKD. ඒ චුට්ටක් exclude කරලා then you move on to the past medical history. Our past medical history is the one that you brought up, no, about the first relapse කතාව ඔක්කොම. So ඒක you can bring it up there. හරිද? So
Yes.
ඒකෙන් start කරාට that is fine, right? But normally what I would do is I will tell this is a relapse, then I will confirm it, and on the day of admission I will talk about the status of the child to tell that the child is not in any sort of an emergency. Like emergencies, there are three emergencies that you mainly need to worry in a nephrotic syndrome. එකක් තමයි shock, hypovolemic shock. එතකොට hypovolemic shock එකක් නැහැ කියන්න you can tell things like reduced urine output, ඊට පස්සේ abdominal pain, right? එහෙම නිකන් like profuse sweating, එහෙම මොකක් හරි එකක් කියන්න පුළුවන්. ඊළඟ other thing is infections, right? So they will have abdominal pain and fever. එහෙම එකක් කියන්නේ ඊළඟට thrombotic events. එතකොට thrombotic events වෙන තැන් තියෙනවා. Like එකක් තමයි deep මේ මොකද්ද renal vein thrombosis. එතකොට renal vein thrombosis එනවා නම් they will present with a sudden onset left sided flank, okay, left නෙමෙයි whatever the flank pain
Yeah.
with hematuria, right? එහෙම ඒ වගේ එකක් කියලා you about this episode also you make sure that you exclude all the possible emergencies that can happen to the child. හරිද? ඊට පස්සේ you will go to the other parts of the first episode. එතකොට first episode එක කියනකොට ඒක you have to like you will be having everyone will be having the template නේ. එතකොට like you all will go with the differential. So එතකොට renal type එක ගත්තා. Apart from nephrotic syndrome, what are the other things you need to worry about? Nephritic තියෙනවා, CKD තියෙනවා, cardiac heart failure තියෙනවා, ඊට පස්සේ cirrhosis, ඔය drugs ඔය ටික exclude කරා. And the way you excluded that was fine, right? So
Mm-hmm.
cardiac past history of cardiac disease, feeding intolerance, where more dependent edema was towards the evening. ඊට පස්සේ cirrhosis එකත් you excluded, right? Yellowish discoloration of the eyes,
Yeah.
hematomesis, melena, right? ඒ ටික ඔක්කොම කිව්වා. That is fine. So ඒක කරන්න ඕන. Then that is fine about the past medical history. And then you symptom analysis was done. Then you went back and described about the past admission. That was also fine. Then what other things that you would need to do is one thing is getting the etiology of the patient, which I found like a little bit it was not mentioned. Etiology එක පොඩ්ඩක් කියන්න ඕන. So because most of the kids will be having a primary nephrotic syndrome, there we
Mm-hmm.
can talk a little bit about things like atopy, like whether the baby had a facial eczema, right? Whether there was any family history of asthma, right? Any other association with the like with the proteinuria with vaccination, viral infection, those things you can mention. And also you have to give clues to exclude the secondary possible secondary nephrotic syndromes like hematuria, right? මොකක්ද having oliguria, hematuria, arthralgias like malar rashes, joint pains, right? Those things and fever and other lymphadenopathies. ඔය වගේ පොඩ්ඩක් කියලා you exclude the possible secondary etiologies also for the nephrotic syndrome, right? ඊට
So little
පස්සේ
bit soon after describing the first episode. Is that so?
yeah. So because now you have to make sure like you describe the first relapse, the current relapse, and make sure that it is not an emergency. Then you go back and talk about like you can change the order. I'm just telling like what I used to do. So ඊට
Mhm.
පස්සේ I will go to the primary medical past medical history and I will talk about the past episode, and then I will talk about the other main components of the HOPC. I will talk about the etiology, right?
Yeah.
Then comes the like after I now I have excluded the life threatening emergencies, but there are still other complications, no? So
Mm.
other complications like we already excluded hypovolemia. We spoke about the cramp in abdominal pain, reduced urine output, cold peripheries that we excluded. And for infections per se, we have to, you have to, there are certain infections that they are predisposed to, like they are predisposed to things like subacute bacterial peritonitis that will get the fever and abdominal pain, right? And in the meantime, you can also ask the mother whether the baby is getting enough penicillin prophylaxis. How is the status of the penicillin prophylaxis? Okay. And
Mm.
then any other skin wounds suggestive of cellulitis, right? Any UTI, dysuria, frequency, those things, and any chest infections you can ask, right? And then when you are like those things has to be excluded in like I would do that when you're talking about the relapse itself. Then the
Mm.
other complications like drug complications, gastritis, and those complications, right? And those kind of complications will be dealt later when after you are done with the first episode. Okay, so
Yeah.
when you're talking about the things like drug complications, that is very important area. So I in your history I didn't find a lot of information about the drug complications. Okay, so
Mm.
you have to talk about now. I used to have a mnemonic for prednisolone complications. um it was some MEBG or something. Wait, let me check with the I don't have it. So in the MEB, I have metabolic, right? So metabolic under metabolic, I used to start the metabolic complications of steroids from polyphagia, obesity, diabetes, hyperlipidemia, hypertension. Those were for the metabolic, and for E is for eyes. They get the posterior subcapsular cataract, and B was for the bones, I guess, and G is for gastritis, and there was a few other complications. You all have to check with some mnemonic, right? So a good
Mm.
name, have a good mnemonic to cover all possible steroid complications. And if this child has been on particular like drugs, so like MMF, if you say they will get diarrhea, leukopenia, loss of weight, those kind of things. And levomisol is another one, so they will get a new like a neutropenia, right? So reversible neutropenia, whether they has had that episode. And if they have been given cyclophosphamide by any chance, you can talk about alopecia, hemorrhagic cystitis, bone marrow suppression, and those any features you can talk. And then they might also be on cyclosporin, tacrolimus, and you will have to talk about hypertension, hypertrichosis, right? And either they had gingival hypertrophy, those things you can take, right? So those drug complications can be mentioned later, right? Right. Then other thing is, okay, so then, yeah, those are the main things for the complications, right? Now let's look at the other parts of the history, right? So other parts, one thing is the immunization. So immunization, you have to talk about, you mentioned about the vaccines that they have received so far. So like extend the history a little bit, and then you can also talk about planning the next vaccine also, right? So he is yet to receive this vaccine, right? You can tell
Yeah.
like that, and you have to talk about influenza vaccine, because if they get a recurrent infection, that can predispose to relapse, right? So even like an
Mm.
existing new influenza can make them worse. And then pneumococcal vaccine and hip vaccine, those vaccines has to be mentioned now. And other thing is, now because these patients are on steroids, their vaccine, the dates can be altered, right? Because now the live vaccines, like they will need the prednisolone cutoff. So they are no, so let's suppose some say less than 2 milligram per kilogram, some say less than around 0.5 milligram per kilogram. I would like I would advise you all to go back and check the Randulas's guidelines for the cutoffs, right? So to when to give the live vaccine, cutoffs are there in that guideline. Read on that guideline. I also can't remember. ඒක කියන්න, right? And all children they should be getting the pneumococcal vaccine. So when you get the pneumococcal vaccine, if your patient is less than 2 years, they should be getting the pneumococcal conjugate vaccine. And if they are older than 2 years, they should be getting the polysaccharide pneumococcal vaccine, right? So read a little bit around that. Don't dig in too much of details, but just know like there these two kinds of vaccines are there. The two kinds of pneumococcal vaccines and when they should be getting each of these vaccine, right? So that is about the vaccination history, right? Then so right then what did I miss? Other thing is the diet history. Diet history was missed neither.
Oh, yes, yes, yes. I didn't
So
think, because when I inquired with her about the dietary history, she was like, the doctors haven't mentioned any dietary changes, so they give the same
yeah,
that they eat.
yeah, that is again like that can be mentioned as a problem also because that's a real problem no? If the doctors haven't mentioned. So one thing is now they have to be like there are certain things about the diet history. One aspect is the salt. So salt intake, you go for a actually salt intake is restricted. There has to be at least a moderate salt restriction, right? And the salt restriction is depending on the level of edema. So when I'll go on to the management also, but like depending on the level of edema only, you will go to a extreme, whether you're going for extreme salt restriction or not depends, right? But some say that salt restriction is needed only if the child is having some certain atypical features of nephrotic syndrome along with hypertension, then only they will restrict salt, right? So so therefore you need to like read a little bit around the guidelines and talk about that. But however you can general as a like a general thing you can mention things like avoiding snacks with high amount of salts and those things you can mention, right? Then the other things is the mainly the pro fat intake, the saturated fat intake, right? So you can tell limiting that or whatever the food that is given after frying it like in deep oil, right? So that has to be stopped. Not every fat on earth is not stopped in these kids. It's like because like around 30 calories they are taken from the fat now. So you need to avoid fat that is like deep fried food you have to avoid, right? And the other thing is the protein diet. So you don't talk about any protein restriction in these kids. Anyway, they are having maybe like most of the Sri Lankans are having low protein diet. So you talk about the ways to optimize them. The most cheapest, one of the most cheapest protein source is eggs. So you can talk about giving them more and more egg whites, right? Not the egg yolk. Egg yolk has a lot of cholesterol, no? Right? Then
Yes, yes.
about the sugar intake, you can tell about cutting down the refined sugars. Most of the kids won't stop eating biscuits, so that can also be brought up as a problem list, right? So they like no biscuit, ice
Mm.
cream, whatever, Coca-Cola and all those things, so you can talk about that. So, and nowadays they say it's not the glycemic index that matters, that the glycemic load is what matters, Kayla. So just like check the recent guy updates on this and like you can modify the diet plan that you are going to give in your management and the dietary history also you can mention. So you can talk about the salt, sugar, fats and fruits, right? Fruits is very important. You don't need to restrict the fruits. There's no issue with the potassium and all, right? Okay.
Mm.
And then this amount of like the diet, you can talk about the diet that the child is following in the ward and the diet that the child is expected to follow at home, right? Both kinds of things can be mentioned, right? So usually at home they should not be restricted, right? Otherwise that will cause like problems with the parents. So they should be on normal diet with all nutrient supplements, but only the limitation should be there only to the fats and sugars, not to the salts, really. Right? So you can tell those things in your management plan and also in the history as well. Right.
Yeah.
And that was about the diet. What else did I miss in the history? Mm, yeah, those were the main things in the history. So let's talk about the management of this patient. Right. So now, yeah. So other thing you said about the steroids. Now, steroids, Welter, you told that. So ideally, if you are going to talk about the steroids, you have to talk a little bit in detail, right? So did you tell the dose of steroids that he was using previously? No, right?
No, I did not tell those.
Yeah. So you can tell about the dose of steroids that the patient was taking during the first episode. And then, like you said, that the child got the second, first relapse while the, like within 1 month period, right?
Yeah.
So then you can tell, like, whether he was on the tapering regime, right? Whether he was still receiving the 60 milligram per meter square amount of prednisolone. Likewise, a little bit you could have mentioned, right? That's fine. And so for that, you need to have the body surface area. So body surface area, it's a must for you to tell in the examination also. And you can tell that whether the dose is appropriate according to the body surface area. You can tell, right? And the
Mm.
complications have to be described. And about the compliance. Compliance to the prednisolone has to be taught, right? So compliance and the like about awareness about the Addisonian crisis that they can get, right? So and how does the mother manage the sick day, right? In the like mild illness, they are supposed to double the prednisolone. In a moderate to severe illness, they are supposed to give IV hydrocortisone. So likewise, how they are like the knowledge about this Addisonian crisis and how to manage the sick day has to be taught, right? And while being on steroids, about the other protective measures that they are taking, like wearing a mask, and about the like live vaccines will be dealt later, right? Wearing a mask, whether the child is allowed to go out and play, those things you can take. And with how the child is going to take the tablets, like that's a good point. Like if the child has to take around 8 or 10 tablets per day. Now let's say it's like maximum they go for about 60 milligram per day now. One tablet is 5 milligrams now, so they will need to swallow around 12 tablets, right? And the prednisolone tablet is very bitter in taste, right? So that will be a real problem for the mother to give the prednisolone tablet, right? So and the prednisolone syrup is very expensive, right? So normally they can't afford to give the prednisolone syrup for that long. So that can be mentioned as a real problem to the parents, right? So how
Mm.
are they giving? Some parents may mukadda crush the tablet and dissolve in it in a sugary drinks also. So that should not be done because this child has to limit the sugars also, right? Those
Mm.
things can be mentioned for steroids, right? And the other thing is, um, yeah, okay. Now, social history wise, social history usually now the school teacher school teacher's part, actually this child doesn't need, but if the child was a school going age kid, so you have to talk about that also, how the school teacher been involved in this part, right? So because
Mm.
like there's no emergency management, but you need to tell the teacher about, like, because this kid will be getting absent frequently, so you need to inform the kids about that. And also, like if there is another sick child in the like the school, if there's another sick child like with chicken pox or influenza, then the teacher can be informed that the like to tell the mother if the other kids are sick, then they can take the necessary measures, okay?
Mm.
Right. So yeah, those are the main things. I don't remember missing anything else. Now, okay, now let's talk about the management of this nephrotic syndrome baby. So for any PED long case, when you're talking about the management, you need to talk about the management in several arms. And this was taken from Sanaguniaka's maker. So first of all, you need to exclude emergencies. Here also we did the emergency exclusion. And then you need to plan the investigations, right? And the general management. And then you have a role of parent education, right? And then you should go to specific management. Obviously, in this one, it will be like controlling the edema and remission induction would be the main thing. And then the management of complications, right? And then the discharge advice. Those are the main five arms where you can talk about the management of any long pediatric long case, right? Right.
Mm.
Now let's see if this child gets admitted with a hemodynamically unstable stage. let's say the child on admission is having a low pulse volume, prolonged low blood pressure, and prolonged capillary refilling time, right? So how would you manage the child, right? So therefore, now that's an emergency situation, right? So now the child is in sort of an hypovolemic shock, right? So hemodynamically unstable child. So there you have to tell the acute management how you would manage at that setting, right? So like admitting to the HDU, informing the consultant, and you go because the child is in shock. It's okay even if you go through the like ABCD protocol. You're okay if the child is talking, airway and breathing is okay, but you will still monitor the child, like connect the child to the multipara monitor, taking the heart rate, blood pressure, saturation, respiratory rate, right? And recognizing the other features of hypovolemia, right? Those things have to be mentioned, right? So like abdominal pain, vomiting, lethargy, and then catheterizing the child and monitoring the urine output, right? Those things. And then now there is a problem with the circulation. The patient is in shock. So the shock is because of the hypoalbuminemia. There is low oncotic pressure, right? And the hypovolemia is because the fluid is getting shifted from the intravascular compartment to from the intravascular compartment, it's getting shifted out, right? So, but in this situation, even though the problem is the hypoalbuminemia, we are not giving albumin at the very first stage because the child is in shock. So at that point, the child has to be given with a normal saline as a bolus. We give 20 milliliters per kilogram of 0.9% sodium chloride as a bolus is the one that is given first, right? Because now, because the child is in shock, the child needs resuscitation. And if you do resuscitation with either albumin or dextran, then actually that is going to collapse the entire microvasculature, right? Therefore, and there's increased risk of thrombosis if you do so. So you have to give them the normal saline bolus, and after the bolus, you can give the albumin. So albumin here you have to give. Um, if you are giving boluses, ideally because like if the child is remains hemodynamically unstable even after your first normal saline bolus, you have to give around 4.5% albumin 10 ml per kg, right? So if the child is somewhat stable, right, then you can go to the 20% albumin, but you never give the 20% albumin as a bolus, right? Because now, if you give 20% albumin as a bolus, that's going to be a problem because it will like there will be a drastic shift in the fluid status. No, so it is an osmotically active particle. So the whatever there will be a volume overload, and they can even go to this flash pulmonary edemas. Therefore, you don't give 20% albumin, you give 4.5% albumin, right? You give the 10 ml per kg as a bolus if they are hemodynamically unstable, and if they are hemodynamically stable, of course, you can give start the 20% LB. Okay. Did
Yes.
you get it?
Yes.
Okay. So now 4.5% albumin you can give over 1 hour, but 20% albumin, if you have to give it over 4 hours, right? 20% albumin, 2.5 to 5 ml per kg within 4 hours. Okay. So if you don't have access to 20% albumin, what you can do is you can dilute it into 1:4, right? If you don't have albumin, another option is cryopoor plasma, and you can also use colloids, right? But cryopoor plasma is not the ideal because it is rich in a lot of clotting factors. So it can induce a state of hypercoagulation in this child, right? Anyway, these children are prone to hypercoagulation. Okay.
Mm.
Right. Now, let's say if this child presents to you without shock, right? No oligo, like without shock or any capillary filling time prolongation, those things are not given. So then you can start the patient with albumin, right? So here you can directly go and start the 20% albumin, 2.5 to 5 ml per kg over 4 hours you can start, but and you can also add a midway diuretic, right? So that can be done if the child presents to you without shock, right? Okay. So there are other thing is when it comes to the management, now if this child presents with mild edema, right? So this child had only mild edema. So mild edema, then what the entire fluid management they got like mild edema, there is norm they don't need like a salt restriction all they need to do is have a normal salt diet with no added salt. But if this child comes with a moderate edema, then you need to have a fluid restriction up to 80% maintenance, right? And you can, that is the fluid restriction. Fluid restriction will come only if there is moderate edema and onwards, because in moderate edema you go for 80% maintenance, and in gross edema you go for 70% maintenance. So in moderate edema you can also consider adding diuretics, but that should be done only after excluding hypovolemia, right? So diuretic you can usually you add furosemide, right? And then in the if the child presents with gross edema, then you go for fluid restriction of to 70% and higher dose of diuretics. And if there is hypovolemia, then you need to add albumin. Otherwise, you don't need to add albumin unnecessarily. Okay. So
Mm-hmm.
these, like I was also looking at the May guideline and only talking about the edema maintenance. You also can read the guidelines, right? So and so that is about the general management of the patient, right? Controlling edema in the patient, right? So ඒ ටික තේරුණාද?
Yeah.
Okay. Now then, so then we need to go and plan the investigations, right? So I was following my order, right? So when you're planning asked to get the investigations for this child, what are the investigations that you would order?
For this particular child, UFR
Okay, for what?
to confirm proteinuria,
Okay,
and
you can do UPCR, ned? Telling
okay,
UFR and UPCR both.
okay,
Then,
and I would like to order the lipid profile, check for cholesterol levels,
okay,
uh, and ultrasound abdomen to look for the presence of free fluid in the abdomen.
okay,
And
okay. Now, what about full blood count?
yeah, football count. Football count. Full blood count. Are we like to exclude any infections or anything like that?
Yeah. You can order to exclude infection. And other thing is like, because these children can also be hypovolemic, they can have a raised hematocrit.
Okay.
Okay. So,
Yes.
and you will need a UFR, right? And that will show this proteinuria. And you can also exclude the presence of like microscopic hematuria, like that is suggestive of nephritic syndrome. That also can be done. And what about the albumin levels?
Oh, yes, albumin.
Okay. And then the renal functions, electrolytes, those things. And in addition to those, you will also need to do the things to exclude the secondary causes. Like you are not like you can do the things like always like any other infective etiology balana, there are certain secondary causes. You can do the ESR, ASOT, hepatitis B surface antigen, hepatitis C antibody, HIV 1 and 2, those things. And also for the inflammatory pathology and all the kila complements, ESR, ANA, dsDNA, those things, right? And then serum IgA levels also can be done. And then other thing is they might ask whether you will do a renal biopsy in this child or not, right? So therefore you need to know the indications of renal biopsy. I actually can't remember, right? So there are certain indications like if the onset of age is like less than 1 year and those things, just have a look at that. So and they will ask that, and I think for steroid resistant nephrotic syndrome and the one with a lot of atypical features, they will be doing the මොකක්ද those renal biopsy. So have a look at the indications for renal biopsy, right? So that is the initial investigations and initial management. Before I go back, those things were mentioned. ඊට පස්සේ then we have to talk about the remission induction in the child. So remission induction, how are you going to achieve the remission induction? Sorry?
Uh, I'm not sure. Like when this child was started, like even within like his steroid dependent child.
Yeah. So remission induction now. Remission induction normally you start on prednisolone 60 milligram per meter square. That is according to the body surface area,
Yeah.
right? And then and this prednisolone can be replaced with methyl prednisolone if there is an issue with the gut wall edema and absorption issues. Or IV hydrocortisone is not really preferred. You go for IV methyl prednisolone, and then you can usually they have a tail off regime with prednisolone. Just have a look at it and see, like, because I also can't remember the tail off regime of prednisolone, right?
It's
And
given over,
then,
I believe.
sorry, yeah,
It's
every
given.
2 weeks they just tail it
Yeah,
off, ne?
yeah, yeah.
Yeah. And if the child is now having steroid resistant nephrotic syndrome, now you will need to do the renal biopsy, but this one is steroid dependent, right?
Yeah.
So if you're telling a diagnosis like steroid dependent nephrotic syndrome, like, I strongly recommend you to know the definitions, right? So
Mm-hmm.
what is steroid dependent nephrotic syndrome? What is steroid resistant nephrotic syndrome? What is steroid, that frequently relapsing, infrequent relapsing nephrotic syndrome? That just have an idea, like frequent relapsing. Now there has to be like more than 2 relapses in the first 6 months, right? Or 4 relapses in 1 year,
Mm-hmm.
right? And then steroid dependent කියලා කියන්නේ, then you get the relapse during the steroid therapy or within 2 weeks of discontinuation. And resistant කියලා කියන්නේ, even after 4 weeks of treating them with the maximum dose, that is 60 milligram per meter square, if there is no response, that is steroid resistant, right? So remember the definitions by heart. Otherwise, like, don't try to tell the steroid dependent nephrotic syndrome. Right.
Mm-hmm.
So for steroid dependent nephrotic syndrome, of course, there's a place for cyclophosphamide. And in Randuresa's lecture, there, and like it's there in my note also, I have put the second line medication choosing thing. You don't need to buy hard that, but you just know when to give the cyclophosphamide, that is in steroid dependent nephrotic syndrome. And steroid resistant nephrotic syndrome, the management depends after the renal biopsy. And levamisole has a place in frequent relapsing nephrotic syndrome. Know those things mainly, and the others, I don't think they will question about the second and third steps, fourth steps. Know those three: steroid resistant nephrotic syndrome, do the renal biopsy, and then decide. And steroid dependent nephrotic syndrome, if the cyclophosphamide has a place, and frequent relapsing nephrotic syndrome, there is a place for levamisole. So when it comes to levamisole, you should know a little bit about levamisole. That, like, that is not a immune modifying drugs. It is an antihelminthic medication. Okay, so antihelminthic medication, and it is not for induction, really. So inducing remission එකටම නෙමෙයි, it's mainly for maintenance. That's how what some say like that, but Randulasa has told like otherwise also. Right. And the side effects of levamisole, like blood dyscrasias, arthropathies, those things you have to know. And that was about remission induction. Uh, yeah, that was about remission induction. And after that, you need to know about infections and how to sort of manage infections, right? So how to manage infections කියන එක ගත්තොත්, so you need to know. So you need to rule, first of all, when the child comes, you need to rule out any infections in every relapse, right? Can be a chest infection, can be abdominal peritonitis, UTI, right? Any spontaneous bacterial peritonitis or cellulitis, those things. And they will ask you why they are more prone to infections. Then you can tell because they lose a lot of globulins in urine, right? And therefore, they will have less amount of antibiotics remaining in the body, so they are more prone to infections, right? So, and also because of the edema, they will have more fluid in the extravascular spaces. Again, that is a risk factor for making them prone to infections, right? Therefore, usually they should be on oral penicillin prophylaxis, and they are on this oral penicillin V twice daily. And commonest spontaneous bacterial peritonitis, their commonest cause is the strep pneumonia. So there the treatment is it IV benzyl penicillin, right? So IV benzyl penicillin, right? So though, and that is the part for infections. Mm, and they might ask, if the child develops pleural effusion, what you are going to do. So you can tell, admit the child to an acute site bed, position the child, prop up, monitor the saturation, start oxygen, right? And get the inward chest X-ray and give the IV albumin, right? And if there is a like a nephrotic syndrome, child develops a pleural effusion, don't try to aspirate because because that's not going to be like that's not going to be a solution. Don't try to aspirate, right? Right.
Mm.
And the other famous question that they tried like to ask is like a child with nephrotic syndrome develops abdominal pain during the hospital stay. What are the complications? What are the possibilities for that?
Can you like repeat the question again?
So a child with nephrotic syndrome, right, who was started on 60 milligram per meter squares of prednisolone, right, and
Yeah.
develops abdominal pain during the hospital stay. What could be the reason?
It can be again hypovolemic shock,
Yeah, one good
mesenteric
reason.
ischemia,
Yeah, that's a good reason. Mesenteric, sorry.
mesenteric ischemia due to thrombosis,
Yeah, thrombosis. Even hypovolemia itself can cause mesenteric ischemia. Okay.
periton-
Then,
peritonitis.
yeah, that's also a good guess. Yeah.
Um,
Then,
mm,
yeah, the thing is they are on steroids. They can have gastritis, right?
ah,
And
okay.
like the mesentery, they can get renal vein thrombosis, right? So they
Mm,
will have this classic triad of flank pain, palpable masses, and macroscopic hematuria. And there's a lot of infection risk is there, so they can get pyelonephritis or UTI, right? And they are at risk of getting the gut wall edema. So if they get gut wall edema, there's a lot of stretching, right? These stretching will be there, and like because of the gut wall edema, they will have their bowel sounds are also like exaggerated in those states, right?
mm,
And you also need to talk about the other irrelevant things like appendicitis, pancreatitis. Those things also can be mentioned. Okay.
yeah.
And the next common thing that they ask is now the child is admitted and the child is receiving prednisolone. And what would you observe in the daily ward round?
Daily water. I would check the daily weight of the child
Okay.
to see if there's a resolution of the uh, uh, fluid retention, and I would also check his urine output, the input output chart, fluid output chart,
Hmm.
and I would check his vitals, and I will also
Okay.
look for complications. I will assess for like evaluate if the child has any complications. Like I will ask him for again abdominal pain or um,
Yeah, that's perfect. That's how you should be doing it. So usually daily ward round, the assessment has to be done according to the SOAP assessment, right? Symptom, observation, assessment, and plan. So for the symptoms, you can ask about the resolution of symptoms and complications, like the symptoms that should be going down and whether there any symptoms that is coming up, right? So
mm,
when for the symptoms that should be going down, you can ask about the general well-being. If he had any abdominal discomfort because of the hypovolemia, you can ask about that and form urine, right? And
mm,
then for complications, you can ask any infections like fever, respiratory cough, and UTI symptoms, right? And calf pains for DBT, those things you can ask. Then for
mm,
observations, you can have a general look at the child, general edema, respiratory distress, the cannula sites, catheters, and all that. And do check the hemodynamic instability and check the hypovolemia, right? Input output, capillary filling, pulse rate, blood pressure, those things, and check the pleural effusion level in the respiratory system and look at the abdomen for tenderness, right?
mm,
And peritonitis cause tenderness, ascites, abdominal girth can be measured daily, right? You can see like in the abdomen examination, usually they have the abdominal girth, they mark it with a marker, right? So that they
mm,
will be measuring the abdominal girth from the same level every day, right? That you can check. And they will have abdominal wall edema, right? And genital edema. And you should know like if they get the scrotal edema, how to manage clinical, right? They should be bed rest because the scrotal wall can rupture. And they should have good scrotal supports should be worn, and they should be taking bed rest, right? And then assessment will include temperature charts, daily weight. That is important, right? Daily weight,
Mm.
right? And daily input output, and you should calculate the daily balance and the grand balance, right? And urine protein has to be done on daily basis, and other investigations has to be done, right? And the plan is, but when you can discharge the child, right? And when the prednisolone can be tapered off, right? And if they have gastritis and all that, you can add additional medications, right? Right. So yeah, then uh what else from nephrotic syndrome? Other thing is like, if the child gets child's blood pressure elevates during the hospital stay, what can be the reasons?
Steroids could be a reason.
Yeah, so one is steroids. Right. Other thing is like, it can be a reactive hypertension. Now it's because of the hypovolemia, there is splanchnic vasoconstriction. So they will have this narrow pulse pressure, right? And they will have reactive hypertension. So therefore, you should, in those reactive hypertension, you should not give antihypertensives. You should be correcting fluid volume depletion, right? Other
Mm.
thing is salt and water retention itself can cause hypertension, right? And mesenteric glomerulonephritis, like another variant of glomerulonephritis apart from MCD, can cause hypertension, right?
Mm.
Those things are there. And yeah, right. Now, regarding the pathology, right? So, regarding the pathology, what are the things? Now, what are the types of glomerulonephritis?
Minimal change disease
Okay,
and focal segmental glomerulosclerosis,
okay.
the membranoproliferative glomerulonephritis and messenger proliferative glomerulonephritis.
Yeah. So what are the, like, you have to divide it now. So when you ask about the pathology, like the classification of nephrotic syndrome, the nephrotic syndrome can be classified as, like we were telling, one thing was the this histopathological classification. So in the histopathological classification, you have the proliferative conditions and non-proliferative conditions. So non-proliferative conditions tamai MCV, FSGS, and membranous glomerulonephritis. Proliferative tamai membranoproliferative, mesenteroproliferative, acute disseminated or diffuse proliferative glomerulonephritis, and IgA disease and RPGA, right? And
Oh,
for, and you have the other classifications also. No? So you have etiological classification when you have primary nephrotic syndrome and secondary nephrotic syndrome. So secondary nephrotic syndrome can occur in vasculitis, SLE, HSP, heavy metals, and all those things. And then you also have a clinical classification. So clinical classification is the one that you were telling, like initially, like steroid responsive, steroid resistant, frequent relapsing, infrequent relapsing, steroid dependent. Those things are clinical classification, right? So if they ask
mm.
to classify nephrotic syndrome, you have to talk about these, all these three types of classifications: etiological, histopathological, and clinical classifications. Okay.
Okay.
And yeah. Okay. And levomisole, and other thing they would ask is, how do you suspect MCD? There you can tell the age in between 1 to 9 years. No hematuria, no raised blood pressure, no deranged renal functions. Those things you can tell, right?
Mm.
And other thing they will ask is, why would they not respond to steroids? So one thing is, it can be steroid resistant. It can be poor compliance, right? Other thing is the quality of prednisolone also. It matters. Now, if you're taking prednisolone from a large bottle on daily basis, then the prednisolone will get exposed to air and moisture, so the quality will go down, right?
Mm.
Other thing is, they will ask about the ways in which you are going to monitor the level of edema. How will you answer that?
Well, we can. General examination, weight chart,
One is daily weight chart. Yeah.
daily weight chart, and fluid input output chart.
Yeah.
Mm,
Input output doesn't give an idea about the edema. No?
uh, uh-huh.
Oh. So other thing is like you can do subjective measures and objective measures, right? So subjectively you can look at the periorbital edema, right, by yourself. And then objectively you can have abdominal girth. I told you like they mark the tape in the abdomen. So you'll be measuring the abdominal girth from the same site like throughout the hospital stay, right? So
Yeah.
one thing is abdominal girth. And you can measure if there's a pleural effusion, level of the pleural effusion, which intercostal space scale you can have an idea, right?
These
Daily
are
weight is other thing.
these are
And
subjective
level,
measures.
sorry?
These are subjective measures. Is that so?
No, these are objective, no? So if you go by
Okay.
abdominal girth, those are values.
Okay. Okay.
And the level of pedal edema is the other thing, right?
Mm.
Uh, yeah, yeah,
And
those
what
is
about subjective methods of checking edema?
just the periorbital edema, right?
That's it. Okay. Okay.
And there can be other things. But do it in okay, no? That's all need.
Yeah.
Anything else do you need to ask?
Mm. Yeah, regarding the management of this child, so the management of hypovolemia and edema are two completely different parts, right? Edema is managed one way, and the hypovolemia is managed another way.
No, 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 no.
Like if the child has hypovolemia, then that's why you consider giving uh, albumin, right? 4.5% albumin if it's unstable, and 20% albumin if the child is stable.
Okay.
And for edema is where you consider fluid restriction step by step for moderate, mild, and gross.
Make like when you have hypovolemia and that edema, like I integrated those things. Like if there's mild edema, usually there is no, they won't have hypovolemia also, no. So
Uh-uh.
therefore, that's what I say. If there's mild edema, just go with like like no added salt, right? So
Mm-hmm.
if they have moderate edema, then you need to go for strict salt restriction, and you need to also have that 70%, 80% of the fluid restriction,
Yeah.
right?
Mm.
And if they have gross edema only, they will become hypovolemic.
Okay, okay, okay.
But
And
with moderate edema also, they can be hypovolemic. There you have to make sure that they are euvolemic, and then you can start diuretics. You don't need to give albumin there. But if they have gross edema, then
mm-hmm.
you need to make sure that then only like it should be losing like a lot of fluid for you to become hypovolemic. No,
Mm-hmm.
so
Mm-hmm.
by losing only a little amount of fluid into your extravascular space won't make you hypovolemic. Did you get it?
Yeah,
Right? So then
yeah,
only you should be starting the patient on albumin and all that, right?
yeah. Okay.
Okay.
Yep.
And other thing is these statins and all for kids, usually they are given if they have frequent relapse in nephrotic syndrome. If they have steroid resistant nephrotic syndrome, then for proteinuria reduction, they usually get the ACE inhibitor. I think.
Mm-hmm.
Okay, Ned?
Yeah.
Okay. Then let's see. Okay, bye.
Thank
Bye.
you, Sidi. Bye. Good night.
Okay, bye.
Thank you,
Bye.
Manchana.
Bye.
Good
Bye.
night, all.